Good afternoon, everyone. At the very outset, I would like to thank Dr. Kavita and Dr. Venkatesh sir for giving me this opportunity. So we'll be having musical videos so that everybody is awake. And I don't have any financial interest in this presentation. And the when and why can differ for surgeon from surgeon to surgeon, but the how part will still remain the same. So we will concentrate more on how part because the rest of the two parts are little controversial. Everybody knows what is mix. So keeping all these things in mind that it's an ab interno approach, minimally invasive and early rehabilitation, safety profile is more, minimal damage to the trabecular meshwork. All these things when you need for a patient, you should say, yes, I want to do mix. And all these are complications with trap, but I would still say trap is a surgery. It still remains the gold standard and it has to be mastered by all the fellows. So this is one case, which is steroid-induced glaucoma, 37 years old male who was diagnosed. He was using Predmet eye drops off and on for 3 years. Subsequently, he developed PACC in both eyes, and the left eye had 0.7 inferior notch with NFL defect. So this is the fundus photograph. He had little thinner corneas and open angles. These are his fields. So left eye had early glaucoma. So we thought, okay, what should we do for this patient? He is a young patient. We wanted to keep the option of trap for later. So we decided we'll do a KDB glide with MICS. So we did go ahead with that. The pre-op IOP was 20 on 1 AGM. And on POD1, the POD1, the IOP was 9 and vascular visual acuity was 6/6. AGM was stopped in the left eye. Right eye also had glaucoma, so we thought, okay, fine. After 15 days or like 1 month, 1.5 months from the first eye, we operated the left eye, right eye also, phaco KDB. And post-op 7 weeks and then 1 week later. So the patient, the last follow-up is of 8 months that we have, and the both eyes are off the medication, and IOP is well under control, 17 and 13, best corrected visual acuity 6/6. So now why KDB in this this patient because this patient was young, no sutures, early rehab, future possibility of TRAP still with us, IOP under control on 1 AGM in the pre-op period, and off the medication at 8 months post-op, and already is a steroid responder. And after TRAP, if you have to give for 82 days the AGM, then again the spike can happen. So and it's a moderate glaucoma, so you can do a mix. Now is it angle recession glaucoma, 69 years old male, coming to the free direct side. He had IOP, he was referred for IOP in the left eye, trauma 10 years back. He had RAPD and near glaucomatous optic atrophy. And he was like, I might come for follow-up, I might not come for follow-up. This was his disc, very advanced glaucoma, and he had angle recession in the inferior 180 degrees. Patient came to us with the T-max of 30 and 5/60 vision. So we thought, okay, fine, 2 medications, 30, advanced glaucoma. I'll do a GATT phaco for him. So I did that. The BCVA was on POD1 was 6/12 and IOP was 6. At 1 week later, IOP was 11, and I did gonioscopy, and there was a good scleral shelf seen. At 1 year post-op, the patient is off the medication, IOP is 6 with a 6/6 vision. So this is GATT. So any of the fellows can tell what is going on. This is a low temperature battery in the right hand and a 50 protein in the left hand. And just made the tip plant. And what I'm showing is that it's a very big plant. When it takes the passage, the plant will be just enough to make it just that. Also, take a wheel and it's all the sides everything here got your project of towards the opposite side. And it's a good sign. If you're feeling resistance, good. If you're not feeling any resistance, then should I say that you are ready to supraverted or you are somewhere but not in the center. Now you can see it started appearing from the opposite side. In grabbing over the initial suture, not below it. more accepting. So why GATT? As I told, he is a patient of pre-sight, can't afford KDB, and he did not want sutures in his eyes, and he was on IOP was under control with 2 AGM. So I thought, okay, fine. If he would have been on 3, even more, I would have gone for a GATT, and he had wide open angles. Now comes the post-traumatic case, secondary angle, open angle glaucoma of a 35 years old male who had a trauma with Freykakel, and he had undergone corneal tear repair in the right eye. So he had superior scarring of the conjunctiva, multiple synechiae, traumatic cataract with phacodonosis, and a 0.6 inferior notch. So he had mild glaucoma. This is his left eye was normal, right eye had, because of poor this visualization, the fundus photo could not be taken, and grade 4 open angle with the CD cleft. This was his field, so it is like a very mild glaucoma in the right eye and bipolar thinning on OCD. So he came in May 2024 with the Tmax of 24, and after 15 days, advised Tanito hook with phaco. And 1 month later, in June, we did a phaco Tanito for him. And on POD1, BCVA was 6/9, IOP was 6, AGM was stopped. And at 6 months post-op, IOP is 10 without any anti-glaucoma medication. Why Tanito? Young patient, mild glaucoma, on AGM, only one AGM, and previous conjunctival handling was done when the corneal tile repair was done. So, and he has been on long-term topical drugs post corneal tile repair. So I thought, okay, we have keep the trap in safe, RD in safe, and just do a Tanito hook. Last comes pseudoexfoliation glaucoma, which is the most common secondary glaucoma which we see, and 74 years old female, defective vision in both eyes, and she had pseudoexfoliation in both eyes. She had lost one eye. The right eye is APD, and the left eye had 0.9 bipolar notch, along with old STBRVO and CNVM. This is her fields. She had only this much precious vision, and she was a free patient. She couldn't afford all these fancy surgeries, and I didn't want to do a GATT in this patient because she was 74 years old. So, okay, we thought we will do a bang in this patient. Already for a CNVM, intravitreal injection was given, and it was planned that along with bang, we will do again a second intravitreal injection of Avastin. On POD1, she had 618 vision with IOP of 8, but there was a small blood clot in AC. And at 5 months post-op, she is 6/12, no AGM and IOP. This is my last video. Again, I'm through the phaco part. Phaco before. body band, and I could see the trabecular meshwork. Why bang? Financially weak, free section patient, IOP under control on 2 AGM, coexisting retinal pathology was there, advanced cup, doubtful follow-up as a free patient, and needed early rehabilitation. So we did bang. So there are many publication, retrospective, prospective, again retrospective, showing that in pseudoexfoliation eyes, GATT works. There is publication that micro hook, the Tanito hook works in eyes with glaucoma. Also KDB works. So everybody says, but these are all foreign publications. So we have to have our own randomized control trials and direct comparison between Migs and TRAP to prove that Migs are non-inferior to TRAP. So I'm not going to take much of this thing. And my take home messages will be that we have to choose our patient very judiciously, wisely, and not one size will fit all. We have to be taken into consideration age of the patient, distance of the patient, compliance to follow up and medication of the patient, and keeping all these things in mind, plus systemic comorbidities, then we have to choose our mix. So thank you very much.